Hi, this is Elliot Fishman, and I'm coming to you on Facebook Live or Instagram on the side there. It's great to be here, and I hope everybody is having a good week. Today is Thursday, it's 1 o'clock, and this week I'm speaking about splenic lesions, indeterminate splenic lesions. So I thought I would share some information with you. I was going to do it with some slides, but I changed my mind and I'm doing it without slides. And some of you who were at our course last weekend in Orlando, I gave a talk on CT of splenic lesions. I also gave a talk on CT of the adrenal gland. And in both the talks, I kind of commented on the fact that both the adrenal and the spleen have a lot of incidental lesions. We talk in the adrenal, about 8 or 9% of patients have adenomas. And we make the point that most incidental adrenal lesions are benign. There's been many articles that make the point, even in an oncology patient, an incidental adrenal lesion probably is going to be an adenoma. Now, in the spleen, it always seems to be the same thing. Now, when you think about the spleen, we can say, oh, splenic abscess, splenic infarct. We can say involvement by lymphoma. We could say involvement by metastatic disease. We can say pancreatitis, infarcts. There's a number of things you can think of. So there's lots of splenic pathology. But at the end of the day, in a patient who has no known malignancy or symptoms of left upper quadrant pain, the odds are that everything you see in the spleen is going to be benign. And there was just an article that was published in Radiology in December, I believe, and I forgot the author's name, I'm ashamed to say, that looked at a large amount of patients with splenic lesions, and basically their conclusion was that a patient who has no symptoms of left upper quadrant pain or fullness and has no history of malignancy or suspected malignancy, whatever you see in the spleen is going to be benign. And I really believe that's the case. So what things do we see in the spleen that really aren't significant? We see splenic cysts, and they can measure from a few millimeters to 15, 20 centimeters. The truth is those 15 centimeter or even 10 centimeter cysts tend to be problematic because they cause pain. Often they stretch the capsule, and patients are symptomatic, so the patients will get surgery. We also see patients who've had pancreatitis. Remember, the barrier of the spleen, the splenic artery and vein come in. You can have pseudocysts tracking in. They go subcapsular. They cause mass effect. And so, again, that's going to be a benign process, but it can be symptomatic. Most of the things we typically see are going to be cysts, hemangiomas, and hamartomas. Now, I mentioned when I gave my talk on Sunday, I believe, that I said that with splenic hemangiomas, you don't have the really good pattern you do with hepatic hemangiomas. Remember, hepatic hemangiomas, 90% are classic, maybe more than 90%. Peripheral enhancement and puddling and filling in from peripheral to central. Okay, very, very simple. Now, when you look at the spleen, we do see occasional splenic hemangiomas that are perfect. Peripheral enhancement and then filling in. But a lot of the splenic hemangiomas just don't do a whole lot. They kind of are shown better on the venous than the arterial phase. On the venous phase, on the arterial phase, they're almost hypovascular. There's really no suggestion of vascularity of note. But we do see them, and hemangiomas can be single, or they can be a few, or they can be many. Klippel-Trenaunay-Weber syndrome has multiple splenic hemangiomas, but again, that's like as rare as hen's teeth, perhaps. We then talk about hamartomas. Now, hamartomas are benign lesions, but they can be problematic. If you think about the spleen and the splenic shape, it's really nice and smooth, kind of concave. And then with hamartomas, you have masses projecting off the spleen. It's kind of internal, but it's external. And it's fairly well circumscribed. You particularly see on arterial phase imaging very minimal enhancement, a little bit more than the regular spleen, perhaps. And on the venous phase imaging, it's relatively hypodense or even isodense, but it has a very much what I would call a pseudocapsule. Hamartomas are benign lesions. There's no incidence of malignancy. There's no incidence of rupture, but they do have that certain pattern. And I've seen a number of patients who I've consulted on who are very concerned about a malignancy, and I'll simply say it's hamartoma. And we follow many of these patients for many, many years, and I don't see anything happening to the lesions. So when I see that appearance, I am really comfortable with hamartomas. Now, if you think about what else, so we said cysts, hemangiomas, hamartomas. I feel if I can call it a cyst, hemangioma, hamartoma, no problem. Now, if you see a lesion in the spleen that's low density, but it has poor margins, or there's irregular enhancement, or the spleen's enlarged, then you're into a whole nother pattern. Splenic abscesses are rare, but patients with splenic abscesses are sick. You're not walking around with an incidental splenic abscess. We talk about infarcts becoming abscesses, and we talk about patients with endocarditis, patients with all sorts of cardiac disease developing infarcts. Again, infarcts are wedge-shaped, peripheral. You recognize them. Now, they may be better defined early or late, depending, and they may be single or multiple, or you can see global infarcts. But again, you recognize that. That's not going to be your incidental, oh my God, what do I do with this lesion? Infarcts early are almost always going to be wedge-shaped. Okay, sharply margined wedge-shaped. It's just simply not going to be a problem. Infarcts, you can present with low-grade fever. You can present with flank pain. We talk about abscesses. Again, abscesses, you're a sick patient. I mean, you don't have an incidental splenic abscess that I picked up. You're running a high fever, and you pick it up as part of an FUO workup, perhaps. We don't see all that many. And again, a lot of what I see relates to patients with endocarditis, IV drug abuse. So patients with IV drug abuse, you're looking at the spleen, you're probably looking harder because those are the patients who have infarcts and abscesses. So history becomes very, very important. I think we talk about all of CT, history being very important, but I think in the spleen is especially important. My concern goes up in a patient who's an IV drug abuser. My concern goes up in a patient with trauma. My concern goes up in a patient who has vasculitis, or the patient who's had recent surgical procedure. So all that kind of works together. We know splenic abscesses, what's the cause? Okay, things like endocarditis, things like patients who've had molars extracted and developed infection, patients with diverticulitis. Appendicitis, rare. I can't think of a case right off the top of my head to give you a splenic abscess or splenic infarct, but diverticulitis is notorious for doing that. Diverticulitis also is the most common thing for giving you liver abscesses, right? So it seeds things because it's kind of like a chronic and acute infection mixed together. So it's not surprising that it is indeed going to seed things. Now, when you look at things like lymphoma, the spleen is typically large. We talk about primary lymphoma and secondary. Secondary lymphoma is easier. That means the spleen's involved, you have nodes, maybe liver, multi-organ involvement, and nodes. So the spleen is just one more site of disease. Not very difficult. The cases that are more tricky are the ones where the spleen is the only site of disease. And then when you look at it, and if I gave you the right history, I could confuse you because I can't always tell splenic abscess from lymphoma, particularly when they're low-density lesions. When they're necrotic and there's an air fluid level in a splenic abscess, that's great, but less than 15% of splenic abscesses have air fluid levels. You're not going to see an air fluid level in lymphoma unless the patient's tumor has infiltrated the kidney, you're given therapy, and maybe that's a response to therapy. But I think it's a really good balance and a really good battle of the abscesses and the infarcts versus the normal. So I think it's not going to be a problem. And patients with abscesses are febrile. They have all sorts of constitutional symptoms. You see flank pain, maybe you see some ascites next to the spleen. You see a left pleural effusion, you see elevated diaphragm. So all those are really good secondary signs. Now in lymphoma, as I mentioned, primary versus diffuse lymphoma in the sense that primary only to the spleen, those lesions can be hard. They're often hypodense, not much of an enhancement. They can really simulate just I can't say a benign process, but they may not look that aggressive. When they're irregular or the modeled enhancement, then it's very easy. So we commonly will look very carefully when we stage patients. Remember, it's common to see lymphoma involving the spleen and liver and adenopathy, and we see many cases with adenopathy but no liver or splenic involvement. Now, I should mention one set of splenic lesions that you can become a superhero with. So scenario is this. Patient has a CT scan, typically the ER setting, for some vague symptoms, and one would argue should the patient have had a scan at all. Now you look at the scan, and there are too numerous to count splenic lesions. Excuse me. Sometimes that's what you see. Other times you see not only are there too numerous to count, 1 to 2 centimeter splenic lesions, but you have the same thing in the liver. Liver and spleen, you say lymphoma, metastasis like for melanoma. If there's smaller lesions and the patient's immunosuppressed, you say candidiasis with infection. Almost any abscess can be multi-organ, particularly in an immunosuppressed patient. But there is a process, one of the great mimickers we talk about, that involves liver and involves spleen, multiple lesions in both organs. Both organs are typically large. You may or may not see nodes, usually not, and that's sarcoidosis. So I've seen a number of cases of sarcoidosis with multiple splenic lesions in the 5 millimeter range to 1.5 centimeter range. Sarcoid is typically not known in those patients. They get a scan, and the scan is terrible looking. And only then you work them up and you find out the patient has sarcoidosis. So sarcoid is a really good thing to think about. If you look at numbers, probably 70% of patients with sarcoid have liver or splenic involvement or splenic involvement on biopsy. You may not see it because it's somewhat infiltrating, but it's there. So one of the incidental things is sarcoid. And those cases I mentioned, if you got a chest CT, you would have seen nodes in a sarcoid type pattern. Most of those people never had a diagnosis of sarcoid. They had no chest CT. They just had abdominal pain. And that's what you end up with. Now, the other thing about the spleen, we always see masses when we think about malignancies. We see large spleens. You think about CLL, perhaps. CLL gives you the biggest spleen, salt and pepper appearance. But you can see other things that involve the spleen. And you kind of wonder what infiltrating processes. Well, it's kind of a little bit tricky because once you get a large spleen, if it's a younger patient, you say, oh, maybe this is mononucleosis. That's possible. Mono, you can get spontaneous splenic rupture. You get a mottled enhancement. And the spleen and mononucleosis can look identical to the spleen in CLL, where it goes from diaphragm down to pelvis. Now, with CLL, it's this salt and pepper appearance, which is not the appearance of mono, but there can be some overlap. So I think even when you recognize the spleen's abnormal, figuring out specifically what the spleen is can be very, very tricky. Now, let me just go to the questions here. So I get a few highs from John Biakino, who's not working today. He's back home. And from Mohammed Medwali in Egypt, and from a few other people, Nisha and Nasha, and Mark DePaulis. Mark DePaulis works for GE Healthcare, helps support CTisus, in fact. Works up outside of Boston. And hey, Mark, if anyone has any specific questions, this is probably a good time to ask us. We are, trying to encourage people to ask questions. One of the reasons we post the title for the Facebook presentation is so that people will indeed ask us questions. So if you got a question, let me know. One typical question we get is, what about single versus dual phase imaging in the spleen? If I'm looking for a bleed, if I'm looking for something infiltrating, if I'm looking for some complication, I like dual phase imaging. You don't need to give a large volume of contrast, but good injection, dual phase imaging, maybe 60 and 90 seconds. You want to get away from that really dense early moire pattern where the spleen is hard to read. So that's something it's worthwhile looking at. Here's Nasha. How to distinguish spleen hemangioma from single hypervascular metastasis from unknown origin. I think sometimes with the spleen and hemangioma, as I mentioned, you do get the puddling, which you wouldn't get from a primary. But if you don't see that, and you probably won't see it that often, with hemangiomas in the spleen, sometimes you get that peripheral filling in, so you can look for that. Again, not always the case. I think that the rim enhancement of neuroendocrine tumors is going to be brighter than the enhancement on one of these tumors. So I think it is tricky to always be 100%. And lesions that hang off the spleen can be very tricky to all of us. So it is a great question, and hopefully I gave you a few good pointers, but it's not a question that's going to go away anytime soon. Why are splenic mets fairly rare? Hello from Cape Town. You know, it's interesting. I think the blood flow in the spleen, the same reason, why do you get a lot of mets in the liver? You would say the liver is cleaning the blood. It should do great. It has dual flow supply, but that is what brings it to develop more lesions. And I think very much as you get different types of processes together, you can have the same type of problem. Now, Tasha asked, how do you distinguish a liver met, a splenic met, from just a process like hemangioma? And again, I think when it's obvious, when you have that peripheral enhancement as the classic appearance, that's great. I think hemangiomas do fill in. Hypervascular mets tend to be irregular. We see them occasionally with neuroendocrine tumors, but it can be a little bit tricky. But I think usually secondary signs can be very helpful. But it is not a perfect way of doing things. It is kind of challenging. Do you treat splenic abscesses with percutaneous drainage? Many places do. People have written about splenic abscesses not having an increased risk of splenic rupture. I think depending on the scenario, they may want a culture. So we do a culture, then we will put a drain in at times. So there is something you can do. People have written articles, particularly the Boston people, about how there's no real incidence of splenic rupture when you're doing splenic biopsy. Why are splenic metastases rare? Yeah, it's a good question. You say the spleen gets so much blood, it should do well. I think the RES cells in the spleen are really good, and they monitor really well. But we are seeing more splenic involvement in a number of different patients. But I think it's just the fact the spleen is really, with its gray, white pulp and red pulp, it's really a good way of being able to cleanse the blood without getting some of the processes that we all think about. Okay? Any more questions? I got a bunch of highs, so from anywhere from Cape Town to Egypt to Baltimore and Mayor's Chapel. So maybe what I'll do is if no one has any questions, I'll stop there. My time is up. And if you have any other questions, just ask me on CTisus. And with that, have a great day. Bye.